So our next session focuses on health equity, and it's been one of my pleasures as chair in the expansion of our program in the service of upstate New York to add several types of what I call meta-ophthalmology to our program, which is beyond the typical clinical care and surgery that we do, but actually to care for the community and the associated morbidities that occur with ophthalmologic disease. And we have three of our champions in healthcare in the community presenting this afternoon. And our moderator, Mike DePaulis, will be moderating this session. Mike agreed to forego his introduction because everybody knows him and to save a little bit of time. But let me just say this. Mike has been a staple in this department since he joined us in, I think, 2016. And your knowledge, partnership, and just willingness to move the mission forward has been incredible. So thank you for your service and your help. And please come up and introduce the next section.
Thank you, Dr. DiLoretto. Thank you for my presenters. And most importantly, thank all of you for being with us late on a Friday afternoon. I think it's pretty evident amongst all of us when we think about what we do clinically every day and what we do when we convene for academic summits such as today. We all share a common passion. That is that we want to better understand the pathophysiology of the processes we deal with day in and out. We're constantly in search of better ways in which to treat said conditions. But often what eludes us is the fact that it's all for naught unless we can find a way to bring or leverage these treatment paradigms to our community in an accessible, effective, and equitable way. And I think that's what our next three speakers will bring to us this afternoon. They're gifted clinicians, they're talented individuals, but most importantly, they have the ability to see above and beyond the individual in their chair at that particular moment of time. They're individuals who have devoted a significant amount of time in their careers into trying to solve the issue of bringing accessible, effective, and equitable care to our patient population. Let me start with Dr. Karen Allison. Dr. Allison received her medical training at the Robert Wood Johnson School of Medicine in New Jersey, followed by a ophthalmology residency at SUNY Brooklyn. She then matriculated her glaucoma fellowship at the Ochsner Medical Institute in Louisiana. Upon completion of her formal training, she returned to the metropolitan New York area, which she founded her Dr. Allison and Associates Glaucoma Consultants. After 20 years there, a journey during which she also received an MBA degree from George Washington University, she moved north, rumor has it did so for the weather, to join us here at the Flaum Eye Institute. Dr. Allison is an associate professor of ophthalmology and a member of our glaucoma services team. Among Karen's many academic pursuits is actively promoting equitable access to healthcare for underserved populations. Additionally, she has started a mentorship program here in Rochester, allowing high school students who are minorities with a pathway through which to gain a glimpse at a career in medicine and healthcare. Please join me in a warm welcome for Dr. Allison as she presents the impact of social determinants of health on ocular disease in New York, a comparative study of Monroe and Erie counties. Thank you.
Thank you, everyone. After that session, this is going to be a little bit boring. So today I'm going to talk about the impact of social determinants of health on our population, and we're going to look at Monroe and Erie County. I have no conflicts. So Michael Marmot said, health inequities and the social determinants of health are not a footnote to the determinants of health, they are the main issue. And I think as we go through and take care of our patients, we realize that that is one of the main issues that we have to face. And there's no good evidence that if people are disempowered, if they have little control over their lives, if they're socially isolated or unable to participate fully in society, then there are biological effects. So the social determinants of health has 5 areas that are the main areas. And one is educational access and quality, healthcare access, neighborhood and built environment, social and community context, and economic stability, which we'll go through those a little bit. So we know that there's three levels. There's equality, there's equity, and there's the reality of where we are right now. So with equality, we give patients or people a seat at the table, but they don't have the same amount of power or the same amount of influence. But in reality, the way our world is, that's not the case. There's some that have a lot more influence than others, and some that really doesn't have any and will never have any because of the way the structure is set up. So what we did, we looked at different disease processes in the area, and we looked at to see how we're doing in Monroe County, and we also compared Erie County and the Syracuse area, but I'm going to talk about Monroe County and Erie County. So as we know, cataract is the leading cause of blindness. It's reversible blindness. And glaucoma is the second leading cause of blindness, followed by macular degeneration and diabetic retinopathy. So we looked at Erie versus Monroe County, and we looked at the 2019 to 2022 public available data from VEHSS, American Community Survey, and County Health Ranking. And we also looked at the ADI data from the Neighborhood Atlas. And from that, we were able to compare many of the different diseases and look at different variables in these diseases. So one of the first things that we looked at was blindness prevalence by age, race, and county in this area. And the prevalence of blindness follows the majority of the population. But the rates of blindness for certain demographics are higher than the average. We found that Black patients have a higher rate of prevalence compared to white patients in all counties reviewed other than Monroe County and Yates County. And so treating the population based on the needs of the general prevalence allows disease to unknowingly and overwhelmingly harm certain populations. So this is a graph that shows that overwhelmingly female have a higher rate of blindness, and the prevalence of blindness has also increased in female. But when you look at the county levels, and Kings County is New York City area in Brooklyn County, and we look at Black populations, overwhelmingly, they have a high rate of blindness, except in Monroe County, where if you look at the red is white population has a little higher risk of blindness in that population, and also in Yates County. And I think really the number of Blacks in Yates County is very low. So in those two counties, whites have higher rates of blindness. And when we look at ocular disease prevalence by region, the rates are higher across the state than in the individual counties. And the disease prevalence in Erie and Monroe counties, they closely follow the country as a whole. Now, glaucoma and diabetic retinopathy county prevalence match are lower than the national prevalence. And macular degeneration is prevalence in Erie County for some reason is slightly higher than the national prevalence. And if we look at the data, so we'll look at Erie, Monroe, New York State, and the US as a whole. Now, glaucoma is higher in New York State overwhelmingly than all the counties, but macular degeneration is higher in Erie County than in the US overall. When we look at prevalence by ocular disease rates by age match, one of the things that we've found out was that macular degeneration, as you know, as you get older, you have an increased risk of macular degeneration, and diabetic retinopathy is about the same. But when you look at glaucoma, one of the things that's striking is that the rate of glaucoma as in younger patients is higher than in the other diseases. So at 40, the rate of glaucoma is significantly higher. And as you get older, of course, the rate increases. Now, when we look at race and ethnicity, one of the things that we also realize is that glaucoma and diabetic retinopathy rates of diseases for Black patients exceeded those for white patients in both Monroe and Erie County. And so for example, looking at glaucoma, the rate of glaucoma in Blacks is way higher in Erie County than Monroe County, but it's quite high. And when we look at macular degeneration, it's much higher in Erie County than Monroe County. The other thing that we looked at is glaucoma suspect and developing glaucoma from glaucoma suspect. And one of the interesting thing that we found was that Asian glaucoma suspects have a higher prevalence in New York and New Jersey, and white non-Hispanics had a higher prevalence in Pennsylvania and Connecticut. But when we look at glaucoma itself, it has a higher number of patients with primary open angle glaucoma in African Americans, even though the rate of glaucoma suspects is lower in that group. So one of the things that you can think about maybe that when they show up, they already have the disease versus with Asians and other groups, they actually get their eyes checked so you can catch the glaucoma suspects earlier. So consistent trends across all age groups and states. And this is just a graph showing the Asian population have a high rate of glaucoma suspect, but when you look at glaucoma disease itself, the Black way outweigh any other group. Insured patient population versus glaucoma prevalence. So for the states with a Medicaid expansion, for example, New York, had a lower rate of patients that were uninsured versus Florida that had a higher rate of uninsured. One of the things that we found out is that the states with the higher rate of uninsured patients had a higher prevalence of glaucoma also, which makes sense. So New York had a lower prevalence, even though the population is much more than, say, Florida or even North Carolina that have a lot of patients of mixed heritage or Black patients. And this is just a graph showing that the more uninsured patients have a higher rate of glaucoma versus patients that are insured. Then we looked at glaucoma treatment by age and race. And Black patients in Monroe County are less likely than others to be treated with a surgery such as glaucoma drainage device. And this is 2019 data. This is not updated data. So they are more likely to be treated with prescription drugs than say from the US. So Black patients are less likely to be treated with glaucoma drainage device, more likely to be treated with medication. So in Monroe County, older patients are more likely to be treated with prescription drugs, and they're also more likely to be treated with drainage devices, which I think is because they end up with a lot of patients with advanced glaucoma at that time. So we tend to use a lot of drainage devices at that time versus prescription drugs. So laser glaucoma surgeries are more prevalent on the state and national scales than in Monroe County. So the black line shows that in Monroe County, 36.8% of patients tend to be on some type of drug versus nationally, it's 33.7. So we tend to treat more with medications there. Healthcare access in 2019, uninsured patients in Erie County, Monroe County was about the same. Primary care physicians split, Monroe County actually was better, and I think it's probably because of the university. So the US overall is about 1,330 to each patient, and in Monroe County about 960. And there was more other primary care providers nationwide than say in Monroe County, and these include nurse practitioners and physicians. Social determinants of adult smoking was about the same in both places. Obesity around the same. Food environmental index was high, which is 7.9. The normal is, the rate is 0 to 10. The closer to 10 you are, the higher the food environment index, which means food deprivation. And the percent of adults with no physical activity was about the same across the board. And percent of population with access to exercise about the same across the board. And residential segregation, meaning that the areas of redlining where you have people congregated in certain areas was about 74% in Erie County and 63% in Monroe County. So residential segregation, which is a black-white index of this similarity, where higher values indicate greater segregation, and same thing with the food index. The higher value means less availability of healthy food environment. So this is the area deprivation index by county. So the darker blue areas are the areas where it's highest. And highest means that for education, for resources, for healthcare. And if you notice that there's some areas that are really high, and this area here, that's the area for University of Rochester. So we're surrounded by an area where the state ranking is very high. The other thing we looked at was neovascular glaucoma secondary to diabetic retinopathy. Progression from diabetic retinopathy to secondary neovascular glaucoma significantly correlated with Black African American race, and correlation was also found between secondary neovascular glaucoma and government insurance type. So the prevalence of diabetic retinopathy within the University of Rochester system is around 5 times lower than Monroe County overall. And diabetic retinopathy prevalence was an inverse association with economic status. When we look at gender, it was higher in, diabetic retinopathy was higher in female. When it says other, those are sometimes patients that did not identify what gender they were. As far as race is concerned, even though African Americans did not have the most diabetic retinopathy, they end up having the most diabetic retinopathy with neovascular glaucoma, which was very significant. And the other variable is that patients without high school diploma had a higher rate of neovascular glaucoma, and patient with increased ADI also had a higher rate of neovascular glaucoma, and ADI state ranking also had a higher rate of diabetic retinopathy and neovascular glaucoma than the general population. So other Erie County exhibited worse outcomes in regard to macular degeneration glaucoma prevalence compared to Monroe County. Both counties are still affected by disparities in care and outcomes similar to other areas of the United States. And there's steps that we can take, which we all know: increasing job opportunities, increased education access, improving food stability and health with healthy, affordable options, increasing mentorship opportunities, increasing access to care, and improving the living condition of all communities. So it's critical that we know our population. It's a public education screening programs. You know, we're very, we have a chair that really supports this initiative, and we're very grateful for that. And of course, cultural humanity in working with increased diversity in the workforce. And cultural humility also means listening to our patients and understanding their context, because sometimes they're not able to do some of the things that we want them to do because of their lifestyle or their culture. So those are some of the things that we have to look at. And that brings in what is called cultural competence versus cultural humanity. And the intersection is working with different communities to address some of these inequalities, but understanding where they are coming from and listening to their stories. So some of the things that we have done. So we have the Academy has the Vision Mentorship Program has changed. We have a high school mentorship program here at University of Rochester, where we actually work with students to just get them involved with healthcare. And the Academy has the medical school program where they actually bring students in to get them involved in ophthalmology. And one of the programs that we're trying to work on is the professional improvement plan for all employees, and also to help them with their progress in whatever job they're in for increased job satisfaction. That's a project that we're in the process of working on. The other issue is the Veterans Outreach Center. We're working with them now. I went there, and it's an amazing what they have to offer to the veterans. So we can't forget our veterans. This outreach center is downtown. They have a food bank, they have clothing, they have everything that you can think of. And now we're going to be working with them to create, to do vision screening. So the quadruple aims of healthcare, as we know, is to control cost. Cost is, that's the limiting factor. But the ultimate goal is patient experience and population health, to take care of the people, and of course the well-being of the doctors or the nurses and the staff that's doing this work. And as we all know, healthcare is about 18% of GDP, and each person is allocated about $12,000 per person. And one of the main issues with cost is overutilization of services and misuse. And so one of the principles that we need to think about is increasing access does not increasing cost does not mean great quality. Increasing access does not necessarily mean quality. So we have to come to the intersection of where high quality, cost efficiency and healthcare access leads to better outcomes. And eventually, I hope we get to that point. So in conclusion, these health inequities have been around. We're trying to address them little by little. It's a systemic problem, and I'm hoping that as we move along, that we can share with our residents and our students the need to think in that way. And I think this is where personalized medicine comes in, that we're not all one. We have to think about each patient separately and what's best for them. And I think that's something that we hope to provide. These are my references. I want to thank all the people that have worked with me. Implicit bias is the single most important determinant of health and healthcare disparities. And why treat people and send them back to the conditions that made them sick in the first place? We have to help. Thank you so much.
Thank you, Dr. Allison. Our next speaker, Dr. Rajeev Ramchandran, received his medical education here at the University of Rochester, followed by an ophthalmology residency at Duke University. He then returned to Rochester to complete a vitreoretinal fellowship, upon which he then graced us with his presence here at the Flaum Eye Institute. Along the way, Rajeev earned his MBA degree at the Simon School of Business. He holds the position of Associate Professor of Ophthalmology here at Flaum and is a member of our Retinal Services team. Rajeev is Director of FEI's Population Vision Health Initiative, an outreach program focused on trying to improve outcomes across the very wide demographic, from preschool children receiving vision screenings to seniors receiving annual diabetic exams. Rajeev has received regional and national funding, National Institutes of Health for his work, and his results have been published in peer review literature. Additionally, he has held various leadership positions at Prevent Blindness in the American Public Health Association. Please join me in a warm welcome for Rajeev as he presents Exploring Spatial and Socioeconomic Determinants of Health Using Geographic Information Systems, a Population Health Approach. Thank you.
All right, so I got to thank all my workers, not only you guys who all come out and do all this work, my colleagues and students who are here, but these three individuals have been very, very critical in this research that I'm going to present today, especially my colleague at Buffalo State, Dr. Al DeMerico. So the learning objectives here are to address what we're doing for population health across lifespan, look at geographic information systems, which is a technique that we can use to understand the environment that our patients are coming from, which what Dr. Allison has talked about as well, and then understand what GIS mapping can suggest for preventing patients' access to eye care in our system. So eye health is an important part of public health screening. Many of you have seen this slide, but again, it addresses important health problem, right? So eye health is important. 40 million people in the United States have threatening eye issues. 150 million have poor vision, and it costs $150 billion annually. So this is an important problem. We have a prolonged latent stage for many of these things, or it's preventable, a lot of these issues that we have, if we can detect them early, which we can, if we have the proper infrastructure to do so, from retinopathy prematurity to refractive error, even eye injuries, diabetic retinopathy, glaucoma, cataract, and AMD, the last four being those of aging disease in the eye. So screening and education must be cost effective. So the prevention that we do must be cost effective. And with minimum intervention or inconvenience to patients, we may have to be able to do this. So this is very, very important over time. And this is what the World Health Organization has stipulated for screening, and eye care satisfies these. So this is our traditional uncoordinated siloed healthcare. We have things like vision screenings that the Lions do, that we do, that other community groups do. We have academic medicine, which has its own hierarchical structure. We have community eye care, which sometimes and sometimes doesn't talk to academic eye care in other centers. And then we have this tertiary hospital care, which is really outside of ophthalmology, that we at an academic center have some semblance to be a part of because we are in a hospital setting, but it really does things on its own. So how do we all coordinate all of this? Well, the National Academy of Science and Engineering Medicine put out a population health report. Now it's almost 10 years, 2016, calling for the Health and Human Services to have a national call to action that cites the importance of vision health and tailored a stakeholder and common research agenda across all people who care about eye health. So it also asked the CDC to develop a coordinated surveillance system for eye care, and a common set of standards should be provided by various providers of eye care, including optometry and ophthalmology, in order to address the practice of eye care, especially for the standard diseases that are there in our healthcare setting. So what we're really focused on is increasing access to eye care, and it includes working in traditional settings and also non-traditional settings, really reaching out to the people before they become patients. This also includes community, state, and national needs assessments and support for vision health, which is a lot of what my work has been doing. What Dr. Allison said, and especially in our last slides, is developing this community network and collaborative is very important in doing this. This is not something that the academic center or providers do on their own, but it's something that we work with community partners to really make a difference. Now, eye care is something that's not really been looked at according to national surveillance and even local health data information that's out there. So Robert Wood Johnson and our national health system supporters have looked at healthy cities, 500 cities across the country, and they looked for various data points about why a city would be healthy, like colon cancer screening, blood pressure, annual health checkups, things like that. But eye care really wasn't part of that. So if you look in even our own Monroe County, you look at the Monroe County indicators for public health priorities, and it's dentistry, and it's seeing a healthcare provider, and it's smoking, and it's cancer screening, but there are no metrics really for eye care. So eye care really isn't part of that. The CDC did put out a vision and health surveillance system along with the University of Chicago's NORC unit. And this vision health system is some of the data that Dr. Allison just presented. It's really great to understand kind of what vision health is in our community, but it focuses on data that is captured from EMR systems, electronic medical systems, and self-reported. So it's not really going out and identifying the epidemiological population level health data that's out there, that in our setting, really academic centers have been in the forefront in doing this and utilizing various surveys in the population and various metrics that exist to look at this across the country. Diabetes is actually the only risk factor for eye disease that's tracked and incentivized to be tracked and evaluated in the United States that have relation to eyes. And you can see how the number of people with diabetes have increased over time, especially in our region, from 2004 to 2016, and even more now today. So this is the single most prevalent risk factor for having an age-related eye disease, diabetes is, and diabetic retinopathy, cataract, glaucoma, collectively termed often as diabetic eye disease, has been a serious leader in causing blindness in our country. So diabetic retinopathy, as you know, is a leading cause of blindness in the US working age population, ages 20 to 74. And of course, it can be asymptomatic until vision-threatening stages occur. So annual dilated exams, as we all know, can prevent 90% of blindness, but really this is not done. The best rate is probably 60%. So the HEDIS effective data information set, which is what the National Center for Quality Assurance uses to track quality metrics in all aspects of things, including diabetes metrics, has been out for 30 years. And diabetic retinal exams or diabetic eye exams have been a key part of this since the 1990s. But still, this is not something that is reaching the 80th percent or 90% of the population. The previous studies have reported actually that rate to be anywhere from 23 to 65%, depending upon what kind of population you're looking at. The diabetic retinopathy exam rate is even lower in safety net clinics in the United States, and those are underinsured. So, as I said, diabetic retinopathy is the leading cause of blindness, and as 11% or 12% of the population report vision loss from diabetes. Sorry for the slide here. It hasn't come out so well, but you can see what our diabetes prevalence is in our country. You can see what it is in our state, and you can see that eye exams have really relied around the 60% mark in New York State, and nationally it's about 50%. So how do we improve the surveillance? Well, one of the things we have to do is to see where the people are who aren't getting their eye exams, right? So geographic information systems is a great way to sort of look at this graphically and to understand this in our community. So we have two primary health care systems in our population that have about 2 million people in our area. We are an urban center, centrally located, the city of Rochester, and we have a lot of suburbs and get rural pretty fast. So we have a good mix of this distribution of population. So there's substantial variation also in socioeconomic status. So you can see in this graph here of Rochester and Monroe and surrounding counties that the blues represent higher SES and the more brown colors represent lower SES. And you can see what the distribution is across our area according to the zip codes that our patients are coming from who have diabetes here in the URMC system. So this is the city of Rochester, and you can see there are large areas of brown in this area where there is a low socioeconomic status. So geographic information systems is a computer technology that basically manages and displays and analyzes spatial data. It's useful to visualize our data and identifies vulnerable patient populations in segments. So geographic information systems have been used in ophthalmology, but it's really been limited to mapping disease prevalence and not really risk factors of disease progression or access to care in this case. So our question was, how do we use eye care gaps and look at see how they vary with socioeconomic and geographic factors amongst our diabetes patients and our URMC system. So our method went back to just at the time of the pandemic going on. It's just probably the end of the main pandemic. We did retrospective analysis of 20,000 patients with diabetes in our system, and we looked at the health effectiveness data, incidence of diabetic eye care non-adherence. So what this is what the HEDIS metric says is that if you have retinopathy, you need an exam within a year. If you don't have retinopathy or any evidence of existing retinopathy in your record, then every 2 years is when you need an eye exam. It's a little different than what the American Academy prescribes. So our approach was looking at non-adherence rate by the zip codes and by Medicare, insurance, rurality. We also looked at race and SES status. There was no actual trend in race in our analysis. We looked at Medicaid status within our cohort, and as well as we looked at other databases you can get for the zip codes that we're looking at. And this includes the poverty census and also looking at the rurality status of our zip codes. So we did all this and took this into a RStudio package that uses GIS mapping. It uses a bi-scale package, and it uses something called chloropleth maps, which I'll show you. These are color maps that I showed before here about how the zip codes fare in terms of their various demographics, like socioeconomic status and rurality and number of people with Medicaid and so on. So looking at this, we did some linear modeling, and we looked at the percentage of patients that are insured by Medicaid versus the non-adherence rate. And we found that those areas with higher Medicaid insurance had higher non-adherence rates, which is what we were thinking, because those people who are underinsured or have other issues with their socioeconomic status may also have harder time in getting care. And we found that people in lower areas of economic productivity or in more impoverished areas also had a higher rate of not accessing care. So that's something else we found. And this is also would be in rural areas and in urban areas. And so urban Rochester had the highest area, and there were also rural areas that did have areas with lower SES status that also had higher areas of people not getting their recommended eye care. So rurality itself, though, didn't play an influence, because there were a lot of areas that were considered rural, but the socioeconomic status in those areas was higher. So these areas actually had better outcomes for diabetic retinopathy exams. So in these areas that we found, we really stressed some technologies that we use to increase screening, including the camera-based screening that we do in clinics. So we're at 8 clinics. We have a camera in these safety net clinics that we're working at, and this includes coverage of about 7,000 patients in the URMC system who don't have regular eye exams. Over 80% are from minoritized or low-income populations, and 50% of them are in the city of Rochester, which is hence where our concentration of our cameras are. Our results as of early this year show that 8 clinics have increased their rates of eye exams from 43% to 57%. One even doing better at almost 76%, which is well above the 90th percentile, which is at 68%. We've done screening over 3,000 patients for the last 5 years, and showed that patients needing an eye exam will be assisted to get that eye exam at the Flaum Eye Institute. So of almost 3,000 patients assessed, 54 patients were scheduled at Flaum, and 57% completed this. So again, each level you go, you get an attrition of people not getting eye care. 11% of this population have had some vision-threatening problems, according to the screening, and of those, a little bit more, 58% have followed up with Flaum. So I guess our chairman was also listening to where the need was, and he's established eye care centers in those areas of brown on this chloropleth map, which are areas of lowest socioeconomic status and high rates of poor adherence to diabetic eye exams. And so Geneseo and our South Clinton office both are located in these locations to increase our access to care. We also have our mobilized vision program where we go out and screen in the community. And thanks to a lot of you all who've really been helpful and supportive of this, we've really reached out to areas that are found to be underserved, even according to this GIS mapping project. So it's a novel technique that we did. We looked at cohort level data with Medicare percentage and 2020 census data for poverty and rurality. And hence the generalizability of looking this for other patients, more than just diabetic patients in our system. And the linear regression plus the GIS mapping confirm the qualitative or the quantitative and the spatial correlation that we have, where that there are issues in these areas of zip codes that are underserved. So lessons learned, we know that the city of Rochester is a high area of poverty in an area where there's great need, but rurality alone isn't the reason why people are not getting care. So it's not really travel distance, but the socioeconomic status that really determines why people aren't getting care. And that's the big thing to combat. Our next step is to kind of look at this over the course of 5 years. We've had some data changes at the University of Rochester, so getting the data has been an issue, even in our own system. So that's really an issue kind of going forward in epidemiology and public health. Eye care itself doesn't have very much data out there right now. And with the changes that we're getting in our health system, and I'm not making a political statement, I actually just was making a statement on the need for this data. Jerome Adams was our former Surgeon General under our president's former administration, and he even says that the surveillance capabilities are very crucial for providing proper health care and for enforcing the policies that need to be done to promote health care. And without these robust data and surveillance, we're really having a problem to effectively provide healthcare in the United States on a population-based level. So the question is, will this continue? Will the CDC support the vision and eye health surveillance system? And will there be more data for vision care in the future? So that's yet to be seen. Thank you.
Thank you, Dr. Ramchandran. Our last speaker, Dr. Christine Coward, completed her medical training at SUNY Downstate, followed by an ophthalmology residency at New York Medical College, where she was the chief resident. This was followed by a glaucoma fellowship at Southern California Glaucoma Consultants. Dr. Coward then returned to the metropolitan New York area to practice ophthalmology before she migrated up here to Western New York, first joining the ophthalmology staff at Rochester Regional Hospital and then joining us here at Flaum Eye Institute in 2022. Additionally, most recently, the American University Professors in Ophthalmology Association has invited Dr. Coward to participate in their very coveted 2025-2026 Intrepid Leadership Program. Dr. Coward is an associate professor of ophthalmology here at Flaum and a member of our comprehensive ophthalmology and glaucoma services. Additionally, Christine is medical director of FEI South Clinton office, where she provides a wide range of ophthalmology services to an often overlooked segment of the population. Dr. Coward's clinical care and advocacy efforts dovetail nicely with her research interests, focusing on connecting community with healthcare. Please join me in recognizing Dr. Coward and inviting her to present Enhancing Patient Care, Boosting Food Insecurity Tool Utilization at FEI South Clinton Avenue Clinic. Thank you.
Thank you so much for that introduction. So second to last speaker before Memorial Day weekend. Thank you for still being here and listening. So I'm going to be talking about my health equity quality improvement project, which some of you may have heard about before. I just want to build this up, just talking about what exactly food security versus food insecurity is. So the USDA actually defines this from a household perspective, not necessarily in just individuals. So if you're food secure, at a minimum, your food is available, nutritious, safe, and adequate. You don't have to use any coping strategies or scavenging or stealing or utilization of the emergency food supplies. The USDA defines food insecurity, again, from that household level. So that's going to be difficulty with acquiring enough food to meet the needs of household occupants. All right, this could be temporary or it can be chronic. And the categories are either low or very low. Low is coping strategies exist for you to take advantage of. Very low means that there's insufficient funds, insufficient coping strategies, or insufficient resources. So in the United States, there's about 13.5% of households that are food insecure. 8.4 of that 13.5 is low, and 5.1 out of the 13.5 is very low. So nationally, in 2022, we had 17 million US households that were food insecure. 1 year later, that number increased by 1 million. In New York State in 2023, we had 10.5 to 11.2 households that were food insecure. That was near the national average. The Department of Health had some self-reporting among adults, among individuals, and they stated that 24.9% of individuals in New York State were experiencing some degree of food insecurity. So this was a table from that study where they looked at individuals. I highlighted Monroe County, but of course we're Flaum, so we're everywhere. But in Monroe County, the food insecurity among New York State adults was estimated to be 18.7. So what are some of the resources for individuals who are food insecure? So our places of worship play a huge role for individuals who are food insecure. They have food pantries, and not just for food, but they also have clothing closets for people to take advantage of. Our state has programs for now getting enough funding. For example, the Hunger Prevention and Nutrition Assistance Program, WIC, Commodity Supplemental Food Programs, and the Child and Adult Care Food Programs. For individuals who cannot make it out to take advantage of these food banks, we have Meals on Wheels. Here in Western New York, we actually have FoodLink. By show of hands, has everyone heard of FoodLink before? Perfect. So I just have a couple of slides, borrowed from their website, just in case anyone was not familiar with FoodLink. So they were founded in 1978 as the Genesee Valley Regional Food Clearinghouse. They were renamed FoodLink in 1991, and they service 10 counties in the greater Rochester and Finger Lakes region. Their mission is to leverage the power of food to end hunger and build healthier communities. So their key programs include a food distribution, which most people know them for the food bank. They also have a curbside market. So just like we take our vision van out to service the community, they actually have these mobile markets. They will travel to different areas of Western New York to provide fresh produce in underserved areas. And they also don't just give someone fish, but they also teach people how to fish. That way there's a long-term solution. So they do have culinary training programs. They have a community cafe that pay it forward with the restaurant providing training opportunities for culinary apprenticeship. And this is their website. So over 1 million healthy meals were served since March of 2020, and 94% of their donations go directly to anti-hunger programs. Why do we care? Why do we care? We care because if you have a poor diet, we already know, and we've been talking about this all day, that you have increased diet-related diseases. We talk about diabetes and how it ravages the eye, takes away vision, cardiovascular disease, and also certain types of cancer are related to having a poor dietary quality. Also, people end up in the emergency room. That increases inpatient admissions and leads to higher healthcare costs. And currently, grants and other funding are being pulled from various nonprofits. So as the living costs increase, incomes are stagnated, and it's really sending people to food banks across the country so that they can get the resources that they deserve. So again, why do we care? This is not going away. So Dr. Allison already, put up her slide about the social determinants or social drivers of health. There's, I like the Kaiser Family Foundation because they include food specifically as its own category to address hunger and access to healthy options. To your right, the social determinants or social drivers, you may see that listed in EPIC as either or, but we also adhere to the Kaiser Family Foundation, where we have 6 different areas for the social drivers. So above, if you are food secure, then your food insecurity tool will be green. If you're food insecure, then it will highlight red. And let's not forget the kids. So the situation is even more dire when it comes to children, with 18.9% of them facing food insecurity. Within the city of Rochester, food insecurity rates vary significantly by neighborhood. And in the high poverty areas here, that food insecurity rate can go as high as 30%. So what does that have to do with why I'm here? So the timeline of events, as you all have heard, I'm the medical director of the South Clinton office. We opened in February 2023. FoodLink offered to partner with us to have an on-site food pantry in June of 2023. I was accepted as the inaugural Health Equity Quality Improvement Fellow at the UR Medicine Leadership Fellow here, and that began in January 2024. And I was trying to figure out, what would be the perfect project in order to fulfill those requirements for the fellowship. And it dawned on me, we have this on-site food pantry. We haven't utilized it much, but how can we increase that utilization? And I believe that it shouldn't just be up to our primary care partners or pediatrics. All right, that social drivers is there for all of us. So if you happen to see that it's not being utilized, honestly, there's only 2 questions that you have to ask in order for it to flag green or red. So again, when I looked at the numbers, the baseline data that I took was from the final quarter of 2023, and I saw that 63% of the time, our patients were coming in and they had already been screened for food insecurity. My aim really wanted to be something that was digestible, something that we could actually attain. So I really wanted my team to increase us from 63% to 80% of increasing the utilization of that food insecurity screening tool, and also increasing access to healthy food resources. And I wanted to do this again in a reasonable time frame. We're all busy, we have a lot going on. So by the end of 2024, I wanted us to be at or above that 80%. So this is not a vision test. This is, you're not supposed to be able to read this. But it's the overall current state process map. If you are a patient coming into South Clinton to be seen by the time you arrive and end either all of the steps, going to see the technician if you need testing. The 2 questions that I referenced earlier, I'm going to blow them up just so that we know what they are. Question number 1, within the past 12 months, you worried that your food would run out before you got the money to buy more. If you choose never true, then that tool will highlight green. If you choose sometimes true or often true, that tool will highlight red. The second question, within the past 12 months, the food you bought just didn't last and you didn't have money to get more. That stands as well. Never true is green, sometimes true, often true is red. So those 2 questions actually expanded our process map. No, I was not popular when I brought this project to my team because it adds to an often already busy and burdensome day. However, I explained to them what my vision was and they were on board. So the problem that we're trying to solve, again, this is a cause and effect diagram. We had to look at the policies, the people, procedures, environment, and equipment and supplies. So we know that speaking about any of the social drivers is a very sensitive topic. Our technicians aren't necessarily trained to do that. So I had to have that conversation and impart education on them on how to bring this up. I thought that the social drivers tool really was in a terrible location at the bottom of the storyboard. You might forget that it's there. I mean, how often do you actually scroll down to the bottom of the storyboard? Most recently, I've asked Kelly to move that up just so it's a little bit more apparent. Policies about collecting the SEOH really at the time of this project was relatively new. And also the patients and family might ask, why are you asking about food? I'm here for my cataracts. So kind of trying to figure out, how to meld that in to the patient experience while they're there was another challenge for us. So I imparted some PDSA cycle timeline into this presentation just so that I could share with you that I use education. So again, educating our staff, educating our doctors who work at South Clinton. Again, just letting people know at baseline that there's a social drivers tool in e-record. I use the Strong Star system to boost staff morale. If I saw that, our team was doing an extraordinary job, I wanted to say kudos to them. We also had posted reminders around, and I have a couple of slides about that just so that we wouldn't forget to screen. And also a little note of encouragement and thanks. My QI coach actually dropped off a goodie box with stuff from Trader Joe's, one of my favorite supermarkets. So we had something there just to say, again, thank you for all of the extra work that I was already putting on my team from a day-to-day standpoint. So this is an infographic that was made by one of the medical students. This is promoting diet and eye health. But I really wanted it to be in English and Spanish because also language equity is huge. So I wanted to make sure that our patients who primarily speak English and Spanish, which are the top 2 languages spoken by our patients, that they understood what we were, the information that we were trying to impart for them. So are you wondering why we're asking about access to healthy food and giving them a short blurb about why we're asking, and also just telling them, what are important nutrients for eye health. I was able to present some preliminary preliminary data last June at the faculty colloquium. So after I did that, I just decided that I had an empty wall in the middle of the hallway, so I posted my poster there. That's one of the ways that I reminded people to ask about the food insecurity tool. And also, it really provoked our patients walking through the hallway to ask about what this poster was about. This is a control chart that's in progress. So see if I have my arrow here. So this is the baseline data from about here to the last quarter. And I'm going to show you that at around August, about the second week in August, from here, we were able to achieve that goal and maintain it of increasing utilization of the food insecurity tool by 80%. The little dips here correlate with the fact that some of the doctors or some of the team might be on vacation. So of course that would affect the utilization. But I was very proud that by August, which is earlier than my target date, that we were already doing what I had wanted my team to do. I think of anything that I tell you today, this is something that I'm most proud of. So again, we had the food pantry. And prior to when I started the program, we had only given out 2 bags of food during the latter part of 2023. To date, since last January, we've given out 958 bags distributed to our patients. Thank you. So what's next? So we've been able to maintain our goal, which I'm very proud of. I would love to expand this to other offices. And again, there was a lot of overlap between Karen and Rajeev's talk, which again is on purpose. We can say this 100 times and it's just that important. So perhaps Batavia and Geneva would be possible locations for an on-site food pantry. A manuscript has been submitted, and also to share this with other institutions. So I'm doing a poster presentation at the Global Ophthalmology Summit in Chicago this summer. So in conclusion, if we don't ask, we won't know. And if we don't know, how can we help our patients? So again, that latter half of 2023, we're not marketing the fact that we had an on-site food pantry. And I'm gonna, admit my ignorance. I thought that if we hung the food link sign in the front of our office, that people would ask us. They're not gonna ask. We have to ask them. SDOH should remain in the front of our minds. And I borrowed some call for actions from the Jewish Family Services of Rochester and Brighton, that we really should be advocating for change and access to nutritious foods, supporting local initiatives, and raising awareness about food insecurity. I just want to say thank you to my team, to the Quality Institute for accepting me again as the inaugural Health Equity Quality Fellow. My QI coach, Jan Schrieffer, is from the pediatric hospital. My South Clinton team, Rachel McLean, my office manager, was instrumental in getting me all the data that I needed for this project. And my technicians, my med students, and an 8 South nurse that was helping me as well. These are my references. Thank you.